All right, thank you. My name is Cody McClatchey, and I'm a practicing internist in Atlanta, and I'm president-elect of the Medical Association of Atlanta. And Dr. Morgan McLemore is generously offered to answer some questions that we have about gene therapy. And I'm going to introduce Morgan, and I have some questions that I want to ask him, and we will go from there. Morgan McLemore is Associate Professor, Department of Hematology and Medical Oncology at Emory University. He's the Associate Director of Division of the Hematology for Hemoglobinopathies, Division Director of Classical Hematology of the Winship Cancer Institute of Emory University. He's the Director of the Georgia Comprehensive Sickle Cell Center at Grady Health System, which makes him particularly qualified to have this discussion about gene therapy. Morgan McLemore is board certified in medical oncology, hematology, and internal medicine. He is a member of the Cancer Genetics and Epigenetics Research Program at Winship Cancer Institute of Emory University. He is also a member of the American Society of Hematology and has multiple local and national collaborations in sickle cell research. Dr. McLemore obtained his medical degree from the University of Texas Health Science Center, San Antonio, and completed internal medicine training at Barnes Hospital at Washington University in St. Louis. He went on to complete a fellowship in hematology and oncology at Washington University in St. Louis. After completing his clinical training, Dr. McLemore pursued research training in the laboratory of Daniel Link, studying cytokine receptor signal transduction. Dr. McLemore is dedicated to teaching and mentoring medical students and residents. He is currently course co-director of the second-year medical curriculum hematology module at Emory University School of Medicine, and is also a member of the evaluation committee for the Hematology and Medical Oncology Fellowship Training Program. Since September of 2013, Dr. McLemore was appointed medical director of the Georgia Comprehensive Sickle Cell Center at Grady Health System. Before taking leadership of the center, he managed a large number of sickle cell patients seen at Emory Clinic and Emory University Hospital. His experience in treating patients with sickle cell disease extends over 30 years of his career in medicine. His current research focuses on clinical outcomes in sickle cell disease and other congenital hematologic disorders. In addition, he is active in clinical trials in hematologic malignancies. Morgan,
yes.
Let me start out by asking you to define gene therapy and the medical advancements that led to its success.
So currently, historically, gene therapy has been involved specifically introducing a gene into the body from outside, usually using a retroviral vector or some type of virus to integrate it into cells and get the cell to produce a protein that it had not previously produced. More recently, there has gone on to include gene editing, and this involves introducing enzymes that are programmed to a specific way to either alter the genetic code or to delete a certain gene. And so basically, you're taking genetic material from outside the body, introducing it and getting a cell to produce that, a protein that it was not previously producing. Although there are some strategies of getting rid of certain proteins that then alters production of other proteins.
All right, thank you. For what medical conditions is gene therapy effective, and for what medical conditions is gene therapy expected to be effective in the future?
So it primarily works best, to this date, the success has been in what are called monogenic disorders. In other words, disorders where there's a single gene defect. Kind of going in the opposite direction, this is not something that's going to help type 2 diabetes because there are multiple genes involved. But in my realm, sickle cell is like the perfect disease for this. It's a single point mutation in one gene, the hemoglobin beta gene, There is a single nucleotide substitution that leads to an abnormal hemoglobin molecule. So you're basically dealing with a single gene defect. Others include hemophilia. There are some recent successes with some retinal disorders, which involve just a defect in a single gene. It's also helpful if you're looking at limited expression of the gene. In other words, it's expressed either geographically or anatomically in a single location like the retina, or with hematologic disorders like sickle cell, it's produced only in the blood and you only have to target the blood or the retina. There are some, exclusions to that a little bit. Hemophilia is they can target the liver to get the liver to produce the protein that is missing. But for the most part, it's not necessarily a great technique if you want to have every cell in the body corrected. It's, you need a specific target that's easily accessible.
So give me a little more insight, and this is sort of a basic science question, I guess, but give me a little more insight on how gene therapy is engineered to have its effect on the target tissues and not have its effect on tissues you don't want it to have an effect on. For example,
Right.
with sickle cell disease, you're trying to target red blood cells, and those are made in the bone marrow.
Yes.
So how do you get it into the red blood cells or into the bone marrow?
Yeah. So that's for blood-related disorders. It's theoretically easy, although in practice there's a lot of hoops to jump through. But you can take bone marrow, either extracted through, a needle into the pelvis and pulling off a lot of bone marrow, or you can give medications that get people to circulate hematopoietic stem cells and remove those through pheresis. And then in the laboratory, you can separate out the immature cells, which will include the hematopoietic stem cells, and then do the gene incorporation outside the body and then put those back in. Other disorders involve, like there's been some recent success with some retinal disorders, and it's basically injecting the vector into the retinal area. With certain adeno-associated viral vectors, they can be given through the hepatic vein and getting them to target, and it can be engineered to target hepatocytes or liver cells specifically. So the techniques broadly, and I'm speaking very broadly here, involve either taking the cell out, which works for the hematopoietic system, and then doing the engineering there and then putting it back in, or just anatomically injecting directly to the site that you want it to be in.
All right. So in the example of sickle cell disease, how do you reconstitute the re-engineered cells?
Exactly. So it does require essentially what we call an autologous transplant. So you've got bone marrow cells with hematopoietic stem cells that have been transduced with the gene product, either gene editing or a engineered retrovirus that will produce the new protein. You have the bone marrow, so you then have to give chemotherapy and wipe out the residual bone marrow, and then you put in the new bone marrow. So it's an autologous transplant. So the person does have to be in the hospital for a couple of weeks for this. And so it's not exactly a, you get a shot and, like in Star Trek, Bones gives you a pill or a shot, and then, within a couple of days, you're good to go. But it does require, chemotherapy, eliminating the bone marrow and allowing the new bone marrow to repopulate.
So describe what the patient experience is like when you're when someone with sickle cell anemia starts this treatment, kind of walk me through what it's like for the
Yeah,
patient.
yeah. So it's actually quite prolonged. They first have to collect enough stem cells to transduce. And this is done by pheresis. They are given medications that will accelerate. So people normally will circulate a very low number of hematopoietic stem cells, which are the master blood cells in the circulation. You can give medications that will increase this number. So they have to, for several months, undergo monthly collections of these peripheral blood stem cells. It's done by pheresis, basically sort of like a fancy dialysis, or the way people collect platelets by pheresis. It's a little bit of a slow process than you would normally do for an autologous transplant, because sickle cell patients can't be given one of the most common drugs, GCSF, that helps move these stem cells into circulation, because they react poorly to it. But that requires several months. And then during this time period, most of the protocols also, pretty aggressive measures are undertaken to keep them from having a lot of other sickle cell problems. They're placed on red cell exchange at the same time to keep the number of sickle cells very low. So this is about a 3 to 4 month process. And then once that's done, the typical processing time in the laboratory is a couple of months. And so you're basically talking about 5 months before they ever get to the gene therapy.
Wow.
And then once that happens, then they're in the hospital for about 2 to 3 weeks after that.
What are some of the more common complications of this process for a sickle cell patient?
They can have a lot of problems during the collection process. The process of giving medications for them to mobilize the stem cells into their circulation can give them a lot of kind of aches and pains, and may precipitate what is, called a crisis in sickle cell. So that's one. They will have to have a large catheter, vas cath, or a temporarily placed for these pheresis. After that, the primary side effect is just usually the chemotherapy. It's usually well tolerated, but they will be in the hospital for a couple of weeks. The white count and platelet count may go down to 0, and there'll be a temporarily increased risk of infections and require possibly some platelet transfusions. That's pretty much the kind of short-term side effects.
All right. So there's obviously a spectrum of disease with sickle cell disease, and many patients achieve adequate control of their symptoms with conventional treatments such as hydroxyurea. Describe, the typical candidate who you would typically, encourage or advise to consider the gene therapy.
Right. And I've had this conversation recently with patients inquiring about it. And I'll give you an example of somebody first that I didn't encourage for it. Young lady, 29, has had one hospitalization in the past 5 years, on hydroxyurea, very well controlled, working full time. I mentioned to her that at this point in time, I would not recommend this. There are some long-term concerns about complications from this. And in somebody this well controlled, doing this well, I would not recommend it at this point in time, but did tell her that this is a conversation we should bring up every year and revisit. Somebody who, I have a current patient who, despite taking their hydroxyurea, being extremely compliant, has had multi-organ failure 3 times in the past 3 years. And multi-organ failure is, if you're not familiar with sickle cell, it's a form of acute chest syndrome where they start having massive sickling. affects their ability to oxygenate, but multi-organ failure is a step further where they develop renal failure and other organ failure. In other words, 3 times, despite adequate and very compliant, he's had life-threatening complications, and he's somebody, once we're up and running, that we will consider doing this for. I think right now we have to be a little cautious in that we don't have a lot of long-term data on this. There has been a few cases reported of developing myelodysplastic syndrome or acute myeloid leukemia post gene therapy in sickle cell. And it may be something specific to sickle cell because the same exact gene products are used in thalassemia and they haven't seen it. So we have to keep that in mind.
What mechanism comes to mind, if any, and how that might happen to somebody? Like,
yeah, exactly. I think we're still a little uncertain about this. Previous gene products, they're targeting the hematopoietic system, have had cases of acute leukemia or myelodysplastic syndrome, so-called, I don't like the term, but people do call it pre-leukemia. And it had to do with the viral vector inserting into a gene and either turning it on or turning it off and then developing leukemia. The newer vectors don't tend to do that. What it looks like is that people with sickle cell may have slightly damaged stem cells, hematopoietic stem cells, and you're putting them under additional stress by having a small number of them repopulate the whole body. So it may be that their stem cells are already a little nicked and damaged a little bit, and then having them repopulate a whole body stresses them further. This is still kind of a work in progress, so to speak. We're still trying to tease this out. Some of the people who developed either MDS, myelodysplastic syndrome, or acute leukemia, going back and looking at their initial samples, it was noted that they had already acquired some mutations that in their stem cells that would make them prone to this. So before doing this, they now undergo extensive testing to make sure that they don't have a pre-existing mutation that could be causing a problem.
Can you test for those mutations before you collect the stem cells, or do you
Yes.
have to wait until after they're taken out of the body?
No, you can test beforehand.
Okay,
yeah.
that's good. Tell me about, this is obviously an expensive process, and tell me about, the real cost and how we can consider that in the context of what society typically is willing to pay for treatments that prolong life and improve quality of life.
Yeah, this is really an interesting question, and one that I struggle with. As somebody who runs a large sickle cell clinic, I do know that we lack funding just to take general care of people with sickle cell. And the current gene therapy products for sickle cell are estimated to cost right at $1 million per treatment. And I think about what I could do if somebody just handed me $1 million, what we could do in the clinic. On the other hand, with sickle cell, and some of the other products have all been around $1 million, and some of them have been much higher than $1 million. With sickle cell, there have been economic analysis showing that it could potentially save money long term. If you were to eliminate hospitalizations or reduce them 100, dramatically, that, over the course of 20, 30 years, you would actually save money. Now, as you are very well aware, and I'm sure most of the people who will listen to this are very well aware in medicine, we're not very good at taking something that has a high upfront cost, but will save money long term.
Right.
That's not something we do well in medicine, and maybe not well in other things either.
Well, the payer who benefits up front isn't always the same as the payer who benefits long term.
Correct. I will add that, there's plenty of examples of medical technology that upfront was very costly and then over time became much, less expensive over time. And I think with all technology, that's the case. We were regaling my son with how much it used to cost us just to have a calculator when we were a kid, which barely did anything. So I think we do have to keep in mind that with technology, cost does come down over time. And
although the process, I mean, unless this process changes due to some really different technologies, the particular ways in which the cells have to be collected over time, and the chemotherapy involved in
it's still going to be
eradicating your bone marrow, this may not come down so fast.
No, you are correct. I don't expect it to come down, at least for sickle cell and some other blood-related disorders. I think from some of the other ones, such as some of the retinal disorders,
right?
Maybe hemophilia, where they're injecting it and then it takes up into the liver. I think the cost of those may come down quicker than hematopoietic ones.
That makes sense. There? This is just, I just thought of this, I guess, but are there, as somebody who has a lot of basic science background like yourself, do you see opportunities for the technology to change and improve, or is this pretty much a technology that is already very far advanced and doesn't really need to be improved? I guess in terms of the sickle cell anemia, the process of harvesting the cells, reconstituting them, holding the patient's hand through all of it. If you know what I'm saying, are there obvious areas where you would direct research to improve this technology?
There have been some work in trying to expand hematopoietic stem cells in the laboratory. In other words, you could reduce the number you would have to collect. So that's work that's in process. There are some work to where you may not have to do chemotherapy. I think those are way off, but what you would do is just periodically over time re-inject stem cells to that over time that you begin to repopulate it. In other words, it wouldn't be a rapid onset, but just doing it over time. But you're right. I don't think there's a lot of huge tweaks at the moment. The vectors have gotten better and better to where you transduce at a higher level. In other words, you're getting more and more of the stem cells transduced, and that's helpful. I think that will get better and better with time. And then there's process of selecting only the transduced cells and not ones that were untransduced.
Yeah, that sounds interesting. And that might help bring the cost down as well. It's been reported that there's a high proportion of sickle cell patients who are good candidates for gene therapy who are choosing not to do it. Can you explain to me what leads a patient like that to decide they don't want to do it?
Yeah, I think a lot of it is fear of the unknown, and concerns about long-term, complications. I've had, previously we were part of a national study looking at bone marrow transplant, allogeneic bone marrow transplant and sickle cell. And for instance, the patient I described earlier, who was doing quite well, working full time with rare hospitalization, is like, I'm doing okay right now. Why don't I see what's happening? Let's see. And lately there have been new medications come out. Albeit they're not the greatest medications, but there have been, new FDA approved medications. There are multiple medications under clinical trial right now, and they're probably thinking, well, let me see what else comes out. But I think a lot of it is just, it is a rather dramatic treatment, and I think there is some concern about long-term complications.
Got it. So,
But
go ahead.
I think that, as we accumulate more data, that may change.
So right now, are the federal insurance plans like Medicaid and Medicare covering this service, and and also are the commercial plans covering this at times?
I they are covering it, and it's almost insurance by insurance. It varies from insurance to insurance. We are not quite up and running in the adult world. My pediatric colleagues have had people go through this. They've gotten it covered. So
I want to ask you about gene therapy in the context of cancer. I know most of your work is in hematology, but
yeah,
I'm not aware of gene therapy being used for cancer yet. I could be wrong about that, but do you see this becoming applied to cancer patients eventually? And if so,
yeah,
which kinds of cancers?
yes. There are some clinical trials, and I don't know a whole lot about it because it's a little outside of my area, but there are clinical trials where you can locally inject and have, the cancer cells take up the gene product to cause, destruction. In some ways, CAR T cells in a way is a little bit where you re-engineer the immune system.
Mm-hmm.
They do transduce cells with the gene product to get it to,
That's
express a
right.
different antigen. So to some extent, that is a form of gene therapy. But
Right.
there are several trials out there looking at
Mm-hmm.
this to try and get the cancer cell to take up a new gene product that will, kill off the cancer cell.
Mm-hmm. I just wanted to, we're getting towards the end of this, and I wanted to see if you could just describe what it was like with a patient of yours that comes to mind going through this gene therapy for sickle cell anemia.
So we currently we do have one patient currently who is enrolled in the trial, one of the ongoing trials in Nashville, and hopefully we'll have this up and running here within the year. But she is having to go up monthly, have stem cells collected, and has had a lot of ED visits with just a lot of aches and pains from this. We are now following about 3 or 4 patients who have transitioned from pediatrics that have had gene therapy for sickle cell disease. And many of them are doing fine. I will say that while it's listed as a curative treatment, and these people are dramatically improved from where they were, biochemically, or when you look at their laboratories, it's not 100% normal. You can still see some evidence of hemolysis ongoing, but they're not coming into the hospital anymore. Now, unfortunately, a lot of people with sickle cell can develop some chronic pain due to bone damage, organ damage, and the gene therapy doesn't fix that. So people who have had not only just gene therapy, but even bone marrow transplant, while you may have taken care of the sickle cell, it doesn't necessarily repair the damage that's already there. And we do have a few people who have ongoing kind of chronic pain that we're kind of dealing with.
It kind of reminds me of my rheumatology patients because as a clinician, you have to decide, you know, how aggressive do I initiate my therapy? You know, do I use the older drugs first, wait for them to fail? Meanwhile,
Mhm.
the disease progresses, you get erosions in your joints, and then by the time you start a biologic, you know, you finally stop the
Right.
disease process. And you know that literature has evolved, and it's gotten to the point now where you know initial therapy actually is the most aggressive therapy.
Yeah.
But what you just described to me is a case for um, over time probably encouraging your sickle cell patients to do gene therapy sooner rather than later.
Right. Right. And we think it, more and more of this will probably, as we accumulate more and more long-term data, and if it, really is starting to pan out, probably the push will be to do this more in the pediatric realm than in
Mhm.
the adult realm.
Right. So, is there anything else that you should tell our audience that I haven't asked? I mean, anything else that would be like an important point to be made, or that we haven't touched on? Because you know what we're really trying to get across is what gene therapy is and
Yes.
what it costs and how well it works. What are the risks?
Yeah.
And I really feel like you have been an excellent person to ask about all these things because you do have a lot of personal and professional experience with it. So, are there any other points to be made that we have not touched on?
No, I think this is evolving. And I think as we accumulate more and more long-term data, the role will become clearer. And I'm cautiously optimistic that it will get us thinking more and more about looking at things from a lifespan.
Mm-hmm.
As we were talking earlier, we're real good about talking about the here and now, but not necessarily what the long-term consequences are and what the benefit of, even if it's high upfront cost of fixing things long-term.
Right. All right. Well, Morgan, thank you so much for your time.
Oh,
This has
my
been
pleasure.
very interesting, and you are a great resource to have, not only at Emory but in the Atlanta area. And although I don't personally see sickle cell patients, I know colleagues who do. So I truly appreciate your time and and your service to the professional community, who the audience is for this.
Thank you.
All right.